I have the pleasure and the honor to announce Philip Castle, one of the world opinion leaders in cervical cancer screening. And he will address a more technical aspect of management of women, in particular women who are HPV positive and PAP negative, or who have ASC-US. Phil, please go ahead.
It seems almost a letdown after the spirited conversation this morning to talk about the more detailed-oriented stuff. But this is really important in the sense that this is where the differences are made. You know, there's no debate over management of HSIL cytology or high-grade disease. You know, we have consensus on that. But this is where these equivocal or low-grade conditions are not just prevalent in cervical cancer screening. We see this show up in cancer screening in general, whether it's prostate or breast or colorectal. It's the management of this low, you know, important but lower risk population that we have to improve if we want to improve the benefits to harms ratio for any cancer screening. Here are my disclosures. Feel free to read those. I'm not going to articulate them. I'm going to cover 4 topics and try to stay on time, my 20 minutes. I do want to talk about HPV positive, PAP negative, ASC-US, and I want to say a little bit about HPV vaccinated populations, and I know Mona Soraya is going to talk about this more, so I'll just touch on it a bit. So when we did the guidelines this year, this is the ACS guidelines, of course, all these things, cancer screening, and feel free, if people want my slides, I'm happy to share them, so you don't have to like struggle to get pictures or whatever. Just email me. Of course, the benefits is cervical cancer prevention. The harms, I've listed a few of the potential harms, and anything that we do in patients have to balance these two. And we had some discussion of that earlier this morning, and we'll probably just come back to this later. In clinical trials and in epidemiologic studies, we don't often have enough cancer to really look at, so we have to use surrogates. The best surrogate is CIN3 or carcinoma in situ, and as Shalini outlined, we don't always have measurements of all these harms, but we use colposcopy as a surrogate for potential harms to the patient. And for our algorithm for co-testing women 30 to 64, you can see that we ended up with co-testing, and if women are HPV positive ASC-US or have an abnormal PAP, they go to colposcopy or other diagnostic procedures. As we'll talk about, one of the challenges is the management of HPV positive PAP negative. And then women who are HPV negative with an equivocal PAP or are co-test negative return to routine screening. We'll talk a little bit more about HPV negative equivocal PAP also, because there have been some additional data that's come out since these guidelines. The key point here, you know, and this is Jack Kuzik's slide, and I've sort of modified it, is that we continue to see that HPV testing is more sensitive than Pap smears by almost a factor of 2. And so it's pretty intuitively obvious that a lot of the advantages of HPV testing is going to be found in the HPV positive, Pap negative. So from an etiologic fraction standpoint, if you will, to use it liberally, a big bulk of that CIN2-3 that we want to find, or particularly CIN3, is in that HPV positive, PAP negative, and we have to be smart about how to find the disease in that population. Just a reminder that one of the consequences of using HPV testing is it's less specific, so we're going to have this big cohort of HPV positive, PAP negative with a lot of disease overall, but not a very high absolute risk, and then how do we extract or how do we find the disease in this sub-cohort? So obviously the added benefits of HPV testing versus PAP alone is the HPV positive, PAP negative subgroup. The management of this group is critical to optimizing the use of HPV testing. Many or most CIN2-3 will be found in HPV positive PAP negative. Among PAP positive, most CIN2-3 will be preceded by an ASCUS PAP. This may be, there may be differences between populations on how much is found in these, but at least in screening in well-screened populations, this is where a lot of the action occurs in these low-grade equivocal HPV positive PAP negative groups. So HPV positive PAP negative, whoops. We have sort of two options. One option is a short-term follow-up to identify women with persistent HPV, and I'll show you some of the evidence that supports that. The PROSER permits a lot of benign infections to clear. I'm not going to show you the data, but we've looked in many cohorts now, and we see that roughly half of the infections go away within 6 months to a year, and somewhere between 70 to 80% go away by 1 to 2 years. So the longer that you can wait with a certain threshold of safety, the better off you are, because a lot of the garbage, the things that you don't want to find, will go away unnoticed. One of the cons, and we talked about this a little bit this morning, is that in opportunistic programs, you have a serious consideration about loss to follow-up. The second option for management of HPV positive PAP negative is if you have 16, 16, 18, or perhaps 16, 18, 45 detection. Right now we only have guidelines for the first two, but I want to also acknowledge that there's companies that have gotten FDA approval for 16, 18, 45, and other companies that are considering this. The pros are you find CIN3, more CIN3 immediately. The con is that there's additional referral to colposcopy, and there may be added costs. And that really comes back to the main issue here, is that we can always do more, we can always reduce risk, but it comes at a cost both to the patient and to the payer. I'm picking on Suzanne Keir's data today, but we certainly could go to other cohorts to find similar data. You can see that this is among PAP negative populations. You can see the very high absolute risk following a single HPV 16 detection. You see that 1833 and 31, sorry, the absolute risks are much lower. And then once you've excluded some of these higher risk types, there's not much difference between the HPV negative and the HPV positive. And really the point is, and we'll come back to this in talking about vaccinated populations, is that 16 and 18, and particularly 16, are the drivers of positive predictive value for a HPV test. If you wait a certain amount of time, and and what I mean is a year or two, and you measure persistence at some level, whether it's type-specific persistence or surrogates of persistence like double positive, you can see that the risk really starts to climb very quickly. Even in double positives here shown in blue, the absolute risk gets to be 20% for hybrid capture 2 repeat positivity over 2 years. So 2 year, at time 0 here, let me put this on scale, that's the second measurement, 2 years apart, and you can see that the risk is really quite significant. And we've shown the same kind of graph in guanacostomy with 1 year intervals testing. So the main point is that a little bit of persistence, even a year or two, represents a significant risk to women for CIN3 and cancer. And that's essentially the basis of one of the options for management, which is to just allow for measurements of persistence, short-term persistence. And I think I've made the case for why 16 and perhaps 16 and 18 are important, but you'll see more data on that in a moment. HPV positive ASCUS, and I'm sorry, that's a typo. I'm going to talk about ASCUS in general, if I can get it to move. So this is the 2006 ASCCP guideline recommendations for ASCUS, which I'm sure you're familiar with, and I just want to bring your attention over here. In the US, there's been widespread adoption of Hpv triage of ASCUS. So if a woman has an ASCUS PAP, the residual cytologic sample is retested for HPV by an FDA-approved test. If they're positive, they go to colposcopy, and I'll show you data that, in a moment from Kaiser showing that the risks associated with HPV positive ASCUS are quite similar to LSIL. And so equal management for equal risk, we send them to colposcopy. We didn't have much data at the time in 2006, so HPV negative ASCUS was sent to repeat cytology in 6 to 12 months. In the new recommendations that just came out, we revisited this issue, and it's no longer repeat cytology in 6 to 12 months. The recommendation is that if the women are being screened by a triennial PAP, if they're HPV negative ASCUS, they return to routine screening, which is 3 years. If it comes out of a co-testing, they go to 5 years. So HPV negative ASCUS is treated as if it were a normal screen. However, since that, and this is work by Hormuz Kaki and Marc Schiffman, looking more closely at the risks. So we went back to Kaiser, the initial publication many of you are familiar with. We looked at 330,000 women. They've gone back and expanded that database to 1 million women who've undergone co-testing. And we were looking much more closely in fine detail about the risks. And so let me bring you to this part of the graph here. You can see that the HPV negative ASCUS is not much different than PAP negative, which suggests that they should be managed similarly. And so what's being considered now is whether to step back from that 5-year interval for co-testing where HPV negative ASCUS occurs, and maybe it should be a shorter interval, maybe it'll be 3 years, where it hasn't been decided yet. This is just to illustrate the point that I just made, which is that the HPV positive ASCUS has very similar risk to the LSIL population shown here. Here's your LSIL by age. Here's your ASCUS, and actually at Kaiser was slightly an elevated risk. But if LSIL is your benchmark for sending women to colposcopy, then it makes sense to send HPV positive ASCUS to colposcopy. And just a few words on HPV vaccinated populations, and I know we'll cover this, but it's going to be an increasingly important issue. This is data from the Athena trial, a couple publications, and looking at stratification by 16 and 16-18 status. And when you have about a 10 to 15% risk of CIN 2+ or 3+ among all HPV positive ASCUS, you can see that the risk is cut in half when you look at the 16-18 negative population as if it were a well-vaccinated population. Obviously, we need real-world data to look at this, but we can get a sense of what's going to come when we take 16-18 out of the population. And in the cytology negative HPV positive population, we'll see a very similar reduction in risk. Here's your all HPV positives. And then among the 16-18 negatives, when you look at the data from, and sorry, this is not Stoller et al. Marc, congratulations, I've just attributed a paper to you. This is actually from the New Mexico PAP registry. And what we see is that among the 16 positives, you see much higher risk for all cytologic outcomes. And among the other HPV types, you see about a 50% reduction in positive predictive value over 3 years. And then many of you have seen this picture here where we looked at the HPV positive PAP negative and the 10-year risk following a positive result. And what you can see here again is that once you take 16 and 18 out of the mix here, your risk is just barely above that of the HPV negative. And the key point here is that we know that 25 to 30% of the cancers and precancers are going to occur in that population, but the predictive value is going to be quite low. So only a handful of women out of 100 are going to actually have clinically important disease. And so, and I know Nico is going to talk about this some in one of the upcoming talks, is that we're going to need new biomarkers to really manage HPV positive or PAP positive populations, because going back to that earlier slide, remember, it's benefits and harms. And so in a vaccinated population, the benefit of screening is going to go down because their risk, their a priori risk has gone down, but the harms are still up here, they're still high. So in order to rebalance those, we need more specific biomarkers to bring that balance back into more benefit than harms. And I hope people can understand that, and if you disagree, let's talk about that at the end here. But again, there's no perfect screening. There's always harms associated with it, and we have to balance those to do the best for our patients. And this is, as I said earlier, this is one of the conversations in all cancer screening, is how do we optimize benefits to harms, and that of course leads into things like quality for the patients, cost effectiveness, etc. So my final comments. First, ASC-US and now HPV positive PAP negative have been intermediate risk states that have presented management dilemmas to clinicians. HPV testing helps distinguish between high risk and low risk ASC-US. And I think there's an extremely large body of evidence that has shown that throughout the world. And I don't really think there's much debate about this anymore, but perhaps others will chime in and disagree. HPV 16, 18, and or HPV persistence may help distinguish between high risk HPV positive PAP negative and low risk HPV positive PAP negative. And finally, I think there are tremendous opportunities for new, more specific biomarkers. I think that we are going to need them to do a better job of management now, and then we're really going to be pressed with screening of vaccinated populations, because we've taken out the two most predictive HPV types, the two most carcinogenic, which are HPV 16 and 18. And I'll stop there and turn it over to our next speaker. Thank you.
Thanks, Philip. I'm glad that you show, and you're not the first time, the graphs from the Katke paper, which clearly indicate that if you look at over the longer time, that HPV is not less specific than cytology. It becomes even more specific. So this is something which we miss in cross-sectional studies. You have more true positives among HPV positive women than among cytology positive women. So this is a very important public health point that we do not capture from cross-sectional data.